You're watching Ketome TV. Knowledge is power.
So we want to talk now about colon cancer. So we're going to start out by talking a little bit about diagnosis and grading. Why don't you take the lead here and I'll just interrupt with questions.
Okay, well, typically you talk about the diagnosis and grading.
What?
Or the diagnosis part of it and the statistics, the epidemiology. You seem to be well informed of that.
It's the only thing I can understand. Okay, so tell me what?
Well, I think we should just skip and go straight into the causes.
Oh, okay, sure.
I think most people with colon cancer, it's not hard to diagnose colon cancer. You get a PET CT, you get a scope.
Okay.
You pretty well know you have colon cancer, so I don't think there's any really significant diagnostic issues.
But what about, okay. Spoken like a true research scientist, what if I'm Mr. Smith and I'm at home? What kind of symptoms am I going to be experiencing?
You're going to be experiencing pain, and you're going to get blood in your stool.
Okay.
And you're going to have a hard time digesting foods.
Okay.
And lots of diarrhea.
Okay. So some pain, blood and stool, difficult with digestion, and some diarrhea.
And you just feel sick.
And just don't feel great. And those would be indicators potentially that you have colon cancer. Yeah. At which point I could go and have, what did you say? Colonoscopy. A colonoscopy.
Or a PET CT.
Or a PET CT. And either one would tell me, the PET CT with more accuracy, or is colonoscopy fairly accurate?
They're typically found with a colonoscopy because they're more routine, and they're used for people that are high risk.
Okay.
And they're used to look at polyps. But definitely you want to have a PET CT.
Okay, so almost certainly it would be discovered with a colonoscopy, but then follow up with a PET CT, because that's going to help you to see with greater clarity where it is, if there's metastases, how aggressive it is, all that good stuff that we talk about all the time. You'll see on our playlists on our YouTube channel a lot of information about PET CT. And on our blog also, there's some great articles about PET CT. Okay. All right. So now we know. So go ahead.
So the causes of colon cancer, there's two familial type or inherited. There's what we call FAP, and that's caused by mutations in a gene called APC. It's inherited in families, and it's basically what you have is you have this high carpet of polyps on the interior of the colon.
Okay, which aren't necessarily cancerous.
No.
Okay.
They're precancerous. They're considered precancerous.
Okay.
Although polyps are benign by nature, they can turn cancerous. Now, the reason I probably shouldn't get too much into the details of this. It's just basically the location of the polyps is in an area of stem cell differentiation and proliferation.
Okay.
And what happens with these polyps is they create these little bubbles in the skin that get stuck. The cells get stuck, and so normally colon cells get shed often. And in this case, they get stuck in a little pocket of tissue, and they get bathed in these growth hormones and turn into cancers. So that's basically what a polyp is. So the other type of cancer that is hereditary is called hereditary non-polyp. It's also known as Lynch syndrome.
Okay.
And that's based on mutations in DNA repair genes.
Okay.
And a common feature of that is microsatellite instability and what we call mismatch repair.
Oh, okay.
And then there's also somatic colon cancer, and or spontaneous as they call it, and that's based on bad diet and bad lifestyle. So alcohol, lots of alcohol, a lack of fiber is really a big factor. A lack of fruits and vegetables, heavy meat diet. And once again, it's associated with not only with these stem cells in the colon lining, but also with the microbiota There's a lot to do with the microbiota in colon cancer right now. And so a diet rich in fiber and vegetables and fruits creates a anti-cancer microbiota.
Right. So, and that variety you were talking about earlier.
Right. Right.
Okay. So did you say, so just to be clear, there's three?
Three basics.
Okay. There's that inherited.
Two inherited.
There's
And
the
one
APC
spontaneous.
and the Lynch syndrome.
Yeah.
And then there's this, just kind of diet lifestyle.
Yeah. So the FAP, as it's called, familial, has polyps in it.
Okay.
And then the Lynch syndrome doesn't have polyps.
Okay.
It's also known as HNPCC.
All right. And is any one better than another, really, in terms of prognosis?
It depends on the genes.
Depends on the genes.
Yeah.
Okay.
Yeah, the molecular features, in fact. So the next thing that's really important with colon cancers is which side it occurs on. As you know, colon occupies two sides of the body. So you have your left, or your descending, and then you have your right, which is your ascending.
Okay.
Connects, which is the stomach side, and the left side, the descending, is your anus side.
Okay.
So definitely having a colon cancer that's on the left side near your anus is much better than having a cancer on your right side.
Just extrapolate. I know it's obvious to you, but connect the dots so it's obvious.
Well, there's a lot of theories on that. There's a mechanism that we know, but the theory is that because it's closer to the stomach, the food isn't quite as broken down in that area. Or the bolus, as we call it. So it's, there's more likelihood of having active carcinogens in that area. But one of the things we do know that's a complicating factor is the microbiota. In the right ascending colon, we have something called Fusobacterium. And it's quite interesting because these Fusobacteria also travel with the metastasis. So when you get a colon cancer metastasis when you have a right colon cancer and you have a metastasis, that metastatic deposits, whether it's in the liver or the lungs or so on, actually have this Fusobacteria that normally live in the right colon. Now they don't live in the left colon. They're mostly just in the right colon.
Okay.
There's some in the small intestine, but mostly in the right colon. And the problem with these bacteria is they tend to break down chemotherapy drugs.
Oh.
So once again, you're in an area with high activity. And so, when you take these oral drugs and even via blood, they break them down. So what we suggest for people with right-handed colon cancers, when they start their initial chemotherapy, one of the important things is to take an antibiotic immediately prior to starting your chemotherapy.
Help to take out some of that bacteria.
Yeah. And as a Fusobacterium.
Fusobacterium specifically.
Yeah. So there's a lot of doctors actually doing that now.
Okay, that way you don't have to take more chemotherapy, or the treatment that you're getting will have more likelihood of working.
Hopefully.
Yes.
So now we're going to go into the biomarkers that are looked at and that we have data for.
Okay.
And so, I think it's really important that if you have a colon cancer diagnosis, that you make sure your doctor is, number one, looking at these biomarkers.
Okay.
And then what we're going to do is we're going to discuss the standard therapy, which is based on some of these biomarkers. Okay. And I think it's really important. The standard therapy for colon cancers have changed, and we see, quite a bit. We'll see patients getting a standard therapy and not getting the best standard therapy for what they have. And so it's important to understand that a lot of that is based on which side your tumor's on. And so you need to make sure that your doctor is doing the right standard therapy, number one, and number two is looking at the right biomarkers first before they're treating you. And so every colon cancer patient needs to be aware of that. And if there's any questions, get a second or a third opinion.
Now, for those of us at home, what's a biomarker?
A biomarker is a molecular feature of the cancer that can be targeted or has prognostic features.
So again, something people hear about would be like BRCA1.
Exactly.
That would be
a biomarker.
Okay, I've got it.
So the biomarkers for colon cancers are a class of genes called RAS, and there's a few different ones. Typically, we look at KRAS and NRAS. Then there's a class of genes called BRAF. And then also HER2 amplification, which we see in breast cancers. That's in a small percentage of typically left-handed colon cancers have. I think it's about 5% of left-handed colon cancers have HER2 amplification. And then also there's these mutations. Once again, there's this MSI, microsatellite instability and mismatch repair. And as I mentioned, that's specifically in the inherited non-polyp subtype, the Lynch syndrome. And so that's a biomarker, an important biomarker for immunotherapy. We'll get into that. We also see something called POL, E, and D mutations. And they're important. That's mutations in the polymerase gene. And they're important diagnostic features that could be targeted. And then the classic BRCA mutations.
Oh, okay. Those can show up in colon cancer.
Yeah.
Are they more prevalent right hand, left hand, or not?
Good question. I don't really know. I haven't looked at the data, but I would say that they're probably more common in the left, but I'm guessing.
Okay, but fundamentally, what I'm learning so far already is you've got to get some genetic testing.
You have to, yeah.
There's too many possible.
And they do look at RAS and at BRAF, but not every institution does that.
Well, and again, even if they're just looking at one,
right,
that still leaves 549 that they could be looking at.
There's a lot of targeted
that have treatments exactly.
So the standard treatments are typically what we call Capox, which is a capecitabine based drug, and a platinum-based drug. And then we have what's called Folfox. And then there's also Fulfuri.
Okay.
Those are the standard ones. They're typically given randomly. There's not a lot of data application in Canada right now, and that needs to change.
Okay, but what about elsewhere in the world?
Definitely elsewhere in the world, the States, yes, they spend a lot of time on looking at that. So what we now know, and this is something, if your doctor is treating you now for colon cancer and you're using one of these protocols, you need to make sure that your doctor understands the following information that we're going to go over. This is very important. So for right-handed colon cancers that don't have RAS mutations, the first-line treatment, the best first-line treatment is going to be Folfox plus a drug called Avastin.
Okay.
And for left-handed that don't have RAS mutations, the best combination would be the Folfox with a drug called cetuximab, an anti-EGFR inhibitor. And so basically, if you have a RAS mutation or a BRAF mutation, you're not going to get any benefit from EGFR inhibitors like cetuximab or pembrolizumab. So right now, the new standard that we know, the latest and the best standard treatments is if you have a RAS wild type right-sided tumor, that's the bad one, you want to get Folfox plus Avastin, which is a doublet. That's for your first line. If you really want to get an aggressive treatment, then you combine a drug called irinotecan, and that protocol is called Folfoxiri, and you also add Avastin. And that's called a triplet regime. The take-home message is that Avastin, which is an anti-angiogenesis drug, is best for right-sided KRAS wild type, and cetuximab is best for left-handed.
Okay.
So for the second line, you would be looking at, for right-sided RAS wild type, you would be looking at Fulfuri, which is irinotecan based, and you can either add Avastin to it, or a drug called aflibercept.
Aflibercept.
Yes.
So I find that if I just start Googling these things and the type of, it'll come up.
Yes,
so
there's lots of information on them. So now, if you have BRAF mutated colon cancer,
okay.
Now this applies specifically to what we call the V600, BRAF V600 class of mutations. SIDE doesn't make a difference in this case, which is quite interesting. It definitely does with KRAS wild type.
Okay.
And KRAS mutated type. So SIDE doesn't make a difference.
But not with BRAF.
Not
or
with
just
BRAF.
the V600. No.
Yeah, well, most of the data is on the V600.
Okay.
Yeah. So there's 2 new studies on this. There's what we call the SWOG 1406 study, and that includes a combination of irinotecan, cetuximab, which is an EGFR inhibitor. So irinotecan is a chemotherapy. Cetuximab is an EGFR inhibitor.
Got it.
And then a drug that targets the BRAF mutation. It was originally designed for melanoma called vemurafenib. There was another study which was quite exciting called the Beacon study. And in this study, they used a new BRAF inhibitor called encorafenib, and they used a targeted drug called a MEK inhibitor, and that was called binimetinib.
Okay.
And then they also combined that with the EGFR inhibitor.
And what was the benefit of this study?
Significant benefits, because both of these subgroups of patients do not respond well to chemotherapy. So if you have a BRAF mutation, you're not going to respond very well to chemotherapy.
So fortunately, there are these new targeted therapies, and people are responding well to them.
Exactly.
But again, you need the genetic testing to make sure that you know
what
the heck is going on. Okay.
So for Lynch syndrome, if you have MSI mutated, or which is called microsatellite mutated, or mismatch repair mutated, that's genes involved in repairing mismatches in DNA during the replication cycle, then you're a perfect candidate for immunotherapy.
And when you say perfect candidate, you don't just mean your doctor would give it to you. You mean it's going to work really well for you?
Actually, in Canada, we've been fairly successful in getting immunotherapy for patients that have MSI. Whether sometimes it has to be through their insurance companies, but usually the doctors are very supportive of that. And so the reason MSI is an issue or provides benefit to this group of patients is because what it creates is a high level of mutations in areas that are not encoding for genes. They're called microsatellites. And microsatellites are also used in forensic and paternity tests. Everyone has their own unique set of microsatellites, and they're inherited in families, and that's how they can tell if you're associated with a certain family or not. So if you have microsatellite instability, that means these microsatellites are going to be altered and mutated quite a bit from your normal cells. And what that does is it makes these cells, the tumor cells, stand out in a big way to the immune system because there's so much variation. And so the immune system is able to recognize these. Now, as you know, in cancers, the immune system gets shut down. And so these immune drugs like PD-1 inhibitors and CTLA-4 inhibitors both reactivate the immune system. They remove the brakes that the cancer cells put on the immune system. And so immune therapy works really well with these cancers. Pembrolizumab, one drug that works quite well as a single agent. Combining nivolumab, a PD-1 inhibitor, and ipilimumab can be very effective too. And also Pol E and D mutations. Now, recent data is showing that a class of mutations called ATM mutations that are also involved in DNA repair are also effective prognostic features for MSI high cancers or for immunotherapy. We don't have a lot of data on that yet in colon cancers, so I don't really suggest using that as a guideline. But if for people that don't have MSI high, they're starting to use a combination of the standard treatment FOLFOX and the PD-1 inhibitor in MSI normal patients. And that study actually got some really good results.
Did it?
So you don't necessarily have to have MSI to get benefits from immunotherapy. I think we're going to see these unique combinations more common now that include immunotherapy and chemotherapy, and that are working on people without MSI or mismatch repair deficiencies.
And again, though, you have to have had that genetic testing
Gotta have that
to be
genetic
able to
testing.
see which of these mutations are happening for you, and
Exactly.
therefore which
Exactly.
of these options are going to be best for you.
Precision medicine.
Yeah.
So for patients with HER2 amplification, there was a recent study called the Heracles,
Okay.
or Heracles.
Heracles, probably.
Heracles,
I'm thinking.
Heracles.
Well, all right. Now you know how it's spelled anyway.
So in this trial, they were, I think it was in advanced patients. They were given Herceptin, which is a drug for HER2 used for breast cancer, and a newer version of a HER2 inhibitor called lapatinib.
Right.
They combined the two drugs together, and they got a 30% response rate in this. So that's quite significant.
Now, again, for those at home, what does a response rate indicate?
So if you have 100 patients with the disease, and you give them all the drug, and 30 of them respond to the drug, in other words, they have more than 30%. The complete response would be more than 30% tumor shrinkage. Responses are based on what's called the RECIST criteria. And that basically just, they're separated into a complete response, which is more than 30% shrinkage in the tumor, and a partial response, obviously, which is less than 30%, but some tumors respond, some don't. Stable disease, where you get no growth and no change. And then, of course, you get progressive disease. So no response. So you get 3 different responses.
Taking us on a side journey here, how is it that scientists call something that's got only 30% response a complete response?
It's more than 30%.
More than 30, okay. But not 100. To me, complete is 100.
Well, this is just in the duration of the trial.
Okay. So complete. I'm still trying. I understand you didn't write this whole protocol for how they use these. We have to go through. Okay, we're going to do that because I need to understand these things.
The RECIST criteria right now.
All right, fine. Point is, they had the best response they could have.
Yes, they had a great response.
Based on that criteria. Okay, got it.
They had responses.
We will do something on this RECIST criteria, so we can all understand that better. Okay.
So other drugs are right now are or mutations to look for, genes to test for, are mutations in the TRK gene. There's some early basket trials, which means that they look at multiple different types of tumors with the mutation. And they use TRK inhibitors, and there was a group of colon cancer patients in there, and they got some great responses from them. I don't have all the data on that. There's a new drug called CEA-TCB, and that is what we call a BiTE, a new class of drugs called BiTE, bispecific antibodies.
Okay.
And what they do is they combine 2 drugs together. So they have an antibody and either a chemotherapy agent or some sort of targeted agent, a biological agent. And so one part of the drug will seek out and identify is an antibody that seeks out and identifies a structure on the cancer cells. And the other one is the active component. They're called BiTEs, bispecific antibodies. They actually bring 2 cells together.
It's like a hunter and their dog or something like that.
Yeah, so we won't get into the details of that because it's a little more complicated than that.
Another time.
So in this particular drug, this CEA-TCB, it targets something called CD3 and CEA, which is one of those tumor markers that we didn't talk about today.
Okay. And yet,
carcinoembryonic antigen, as it's referred to. And CD3 is a component of the PD-1 signaling pathway. So it brings these 2 together. So in another basket trial, what they did is they included a PD-1 inhibitor with the CEA-TCB drug, and they got really impressive results. It's a basket trial, so it's not specific for colon cancer, but in the colon cancer group, they got some really significant results.
Okay, and we're still talking about the HER2 folks, or are we on to the MSI folks?
We've passed.
We've passed that.
Past MSI, past HER2, we're on other drugs.
Oh, okay.
Future drugs.
Oh, okay, excellent.
So Now we're going to change gears again.
Oh no, I'm just catching up. CEA, fortunately we can rewind.
You could rewind it. Yes.
CEA, TCB doing very well.
Plus atezolizumab, which is a PD-1 inhibitor.
Okay, plus.
It was a basket trial, so we need proper phase 3 trials.
Okay, but promising results.
Very promising results. Yeah.
Okay.
So for late-stage colon cancer, once people have tried everything and they've stopped responding, a great drug came out a few years ago called TAS-102, also known as Lone Surf. We were one of the first companies to use that in Canada, as you know, and we got significant results with it.
Mm-hmm.
We were also able to help a lot of doctors access it through the company. When the company came here, we were still bringing it in. It's called Taiho Pharmaceuticals. We were bringing it in from the States, and it was very expensive. And I called up the company a while ago, and I asked when they're going to get it in Canada. And they said, well, we've had it in Canada for 2 months, and we've been sending out emails to all of the oncologists and all the hospitals, and really no one's getting back to us. And I said, well, send me the form.
We'll get back to you.
So we sent it out to all the doctors that we knew, and they got a lot more responses from it.
Well, that's just a short little sojourn into how busy oncologists are.
They are. They just don't have
how
time
much
to read the
information
emails.
there is.
Even for a free drug that's going to add another year or two to their colon cancer patients' lives.
Yeah.
So a couple things about TAS-102. And when you take TAS-102, so TAS-102 is an old combination of chemotherapy drugs that were reorganized by the Japanese, and it's quite effective. It works differently than other colon cancers, but it's quite effective. It doesn't have a massive effect, but it's definitely good for stable disease and preventing it from growing further. And so it's often used in late lines of colon cancer when there's no other options for the patient. One of the newest things about TAS-102 that we do know is it causes neutropenia, bone marrow suppression.
Okay.
And that can be a negative thing in a lot of cancers, chemotherapy and so on.
Sure.
In this particular drug, it indicates that the drug is going to work well on the patient.
Oh, really?
Yeah, so it's a
it's
good,
kind of the price you have to pay.
It's a positive prognostic feature, and you can take things for neutropenia. There's drugs for neutropenia.
Okay.
And one of the benefits of this, as we mentioned earlier, having a KRAS mutation is not necessarily a good thing. We didn't discuss KRAS a lot, but it's a negative prognostic feature because you can't use EGFR inhibitors, and they play a huge role in standard colon cancer care. So TAS-102 works equally well regardless of your KRAS mutation. And as far as I know right now, it works equally well on both sides, left and right.
Well, that's handy.
Yeah. So one of the studies that was recently out about a year and a half ago showed that that you can give it on an alternate schedule, a reduced dosage schedule. And we're seeing this a lot with chemotherapy drugs, is often the reduced scheduling of the drugs or the alternate schedule where you don't get as much of the drug as you'd normally get is almost or equally effective as a full dose with a lot less side effects. And the patient's able to take it for a lot longer. So the alternate schedule of TAS-102 is quite beneficial and also has a lot less side effects. That also allows you to combine it with a drug, with Avastin, the anti-angiogenesis drug. And when you combine TAS and Avastin together, you get a significantly improved survival rate. Now, we first started using that a few years ago in patients, and a lot of patients have responded really well to that. It's almost doubled from our information, it's almost double the survival. We had a patient that stopped responding to TAS-102 after about 8 months to a year. We thought that was it for him, and we got him on Avastin and put him on the alternate schedule of TAS-102, and he lived another year. He made it through another Christmas. So that was very impressive. That has recently been established in a newer study called the TASCO study. And what they did was they combined the drug Xeloda or capecitabine with bevacizumab, or TAS with Avastin. Bevacizumab is its brand name. I like to call it Avastin.
Okay.
So They combined capecitabine with Avastin and compared it to TAS-102 with Avastin, and they found that the TAS-102 and Avastin was significantly better. Now, there's also the old standby drug called regorafenib. It's been around for a while, but a lot of doctors don't like to use it. It's used in the last line, and it can definitely give you more time, but it doesn't really work in a lot of people, and a lot of people have a really tough time tolerating it. And that's, it's a huge problem.
So what's the upside of that?
The reason it's hard, well, it gives you more time. If you have in the advanced setting.
Okay.
So the reason it's a tough drug to tolerate is it's what's called a dirty tyrosine kinase inhibitor. And so a clean tyrosine kinase inhibitor is a targeted drug that only hits one or two signaling pathways. A dirty one hits many. And so it ends up having a lot of side effects, and patients can't tolerate a proper dose of it. However, there are a group of patients that get what's called cavitation when they take the drug. A select group of patients, we don't have any molecular features to determine why. There are some genetic features that we believe, but we won't get into that right now.
Okay.
There's not a lot of studies on it
Speculative.
yet. Well, it's not speculative.
No.
It's just, it applies in a very complicated genetic background.
Got it.
So I'd have to spend some time explaining how that works.
My head's swimming already with all this stuff.
So when you see cavitation, what cavitation is where the tumor actually grows bigger, but the inside core is dead. And so if you see cavitation on a scan, like a PET CT or a CT or an MRI, when you're on regorafenib, that's an indication that that drug is going to be very beneficial for you.
Okay.
And so if you are taking regorafenib, make sure your doctor looks for cavitation. Very important.
Okay.
Now, there's a couple other things as far as diet goes.
Okay.
There's a great study that showed recently, a Mayo Clinic study that showed eating a combination of 9 different beans, eating a lot of beans every week, having a certain amount of servings, actually extended the lives of colon cancer patients by about, I think it was about 8 months on standard therapy. So really significant data. Eating beans, yes.
Like we're talking like lentils, like the June.
Yeah, it was a 9-bean combination, I think they used. Another thing with certain types of colon cancer, can benefit from aspirin. And that was one of the questions. Yeah. So, and aspirin has also been shown to be beneficial in cholangiocarcinoma, which is a horrible bile duct cancer. So aspirin works on what's called the COX-2 enzyme. It's involved in inflammation processes. As you know, aspirin is an anti-inflammatory, and we believe that that's one of the mechanisms of how it works.
Okay, so lots of beans. Now, how would I find out?
Lots of fiber.
How would I find out which beans, or just kind of load them up?
Load them up.
Okay.
Yeah.
All right.
Load them up.
All right. It's always nice when there's something that you can be in control of.
Totally.
that it isn't.
Fiber.
Yeah.
Fiber, beans.
And aspirin, apparently.
Aspirin. And with the fiber, it changes the composite of the microbiota. I would assume that the beans have a similar process. And as we know that the microbiota has influence over the drugs you take. It could prevent them from working, as in the case of fusobacteria and fluorouracil-based chemotherapy.
Wow, that's really, there's so much to consider, isn't there?
And then, so if you have PARP inhibitor, or if you have mutations in BRCA1 or 2, PARP inhibitors could be effective. I would definitely suggest PARP inhibitors combinations for people that have BRCA mutations.
Okay. But that's kind of perhaps a good point to point out that a lot of times people have more than one mutation.
Yes.
And they can work together against you, or they can work against each other. And so that's why if your oncologist is testing you, say, for one of those common mutations, like let's say
KRAS.
Like let's say
RAF and BRAF.
KRAS, which is great. But if you very likely have other mutations as well. It's very
Most
rare.
definitely.
Very rare we get one of those genetic panel tests back that just has one mutation on it. So understanding all of the mutations that are driving your cancer and how they might work together, or how certain treatments might make them better or worse, it's an important element.
We saw that just recently with the study on ATM mutations. It was a basket study in different cancers, and people that had ATM mutations got a great response, a significant response to radiation therapy. So if you have, and we see ATM mutations a lot in colon cancers. So if you have an ATM mutation, even if there's not a lot of targeted therapies, that indicates that radiation might be more effective for your metastasis than with other patients with colon cancer.
It is important to know, because lots of us, when we think about having a cancer diagnosis, we might have it in our mind, I'm not doing radiation, or I'm not doing chemo.
Well, one thing we didn't cover today, because there's just so much to cover in colon cancer, is the use of liver-targeted therapies. So one of the newest things is called yttrium, and basically what it is radioactive microspheres, and colon cancers preferentially metastasize to the liver, and it's always a difficult situation when they metastasize to the liver. So one of the treatments is this yttrium, and if the tumors are small, they inject these little microscopic radioactive balls directly into your liver. And they seem to work quite well for smaller tumors. If you have an ATM mutation, then you know that even if you have a larger tumor and yttrium wouldn't necessarily be prescribed for you, then knowing that genetic information that you have this ATM mutation, it creates a sensitivity to radiation therapy, means that yttrium Y90 is going to be a much better approach for you than it would be for someone else, and you can use it in situations where they wouldn't normally apply it. For example, if the tumors are too big.
Yes, that's
so. Genetic information is treatment changing.
Yeah,
it really
gives you
is.
so many more options. It gives your doctor so many more options, because they can't just keep trying different things.
No.
They have to have a good reason. They have to know the mechanism for why they're trying it. And genetic testing will provide that.
Thank you for watching Ketome TV. Subscribe below and stay informed.